My name is Lisa Koo. I'm one of the genetic counselors at the Hereditary Cancer Clinic here at the university. And I'm really excited to be moderating this second session. I think that there's already been a lot of interest in this particular topic, so it's going to be great. We have a really packed agenda with 4 different speakers. And we're going to be focusing, really talking about engaging your family and talking about the Lynch syndrome community as well. So without further ado, I'm going to introduce the first speaker. This is Cami Wolfe Schneider. She's a genetic counselor with the University of Colorado, she's working primarily in pediatric cancer genetic counseling, but she has also worked for several years with the adult population as well. And today she's going to be discussing Lynch syndrome in our young population.
Does it take a minute? It's working now. All right, great. Thank you, Lisa. And thank you to the organizers for inviting me. I'm so excited to see all of you today and be able to talk with you about children. How many of you have a child or a grandchild or another child in your family that might be at risk for Lynch syndrome, or maybe a future child that isn't here yet? Okay, so that's a lot of people. Okay, so we talk a lot about adults with Lynch syndrome. So I want to spend today, my portion, just talking about what things do we need to think about for these children you all raised your hands for. So just give a little background on genetics, and we'll talk about a few different things as we go. These are my topics we'll go over. So I know we mentioned earlier that Lynch syndrome is autosomal dominant. You are probably mostly all familiar with that. I'm not sure how many of you are really familiar with kind of the tumor genetics and kind of where this all factors in. So I just want to take a minute so that we're all talking the same language. So if you think about the fact that our bodies are made up of trillions of cells, in every cell of our body, anyone know how many genes we have? About 20,000 pairs. So it's a lot of information, little squiggles, in every single cell of the body. And every time our cells divide and copy into new cells, which they're constantly doing, they have to copy over all that information. So you can imagine with 40,000 instructions for our body, we expect mistakes to happen. And the more and more cells divide, the more those mistakes add up. And eventually that's what leads anyone to getting a polyp or a cancer or a tumor. Cells divide abnormally. And if the cells have the ability to spread to other parts of the body, that's what we call cancer. There are several hundred genes that we know about that their job, like the Lynch-related genes, are involved in stopping this process. So with these genes, the ones we've been talking about all day, everyone typically has 2 copies of them. With Lynch syndrome, usually 1 copy has an abnormality that's keeping it from working. You still have another copy that's protecting you from cancers and tumors, but you just have less protection than other people have that have 2 working copies of the gene. So what happens if when you've got 2 genes, both of them have abnormalities in them? So say you've got 2 parents and both of them have Lynch syndrome. Let's say you come to a Lynch syndrome symposium and you fall in love. It can happen. So if neither copy of the gene is working, then you don't have any protection from that gene. And that's true in all of the cells of the body. And you have this condition called constitutional mismatch repair deficiency, which was mentioned earlier. How many of you heard about this before today, walking in the doors today? Okay, only a couple people. So this is a recessive condition. When you inherit Lynch syndrome from both sides of the family, you have a different condition. You have higher risk for the cancers because you've got less protection. And we also see some physical findings. So have any of you heard of the condition called neurofibromatosis before? A couple of people have. So that's a condition where you can have things like brown spots on the skin we call cafe au lait macules, freckling in spots that don't see the sun, like armpits and groin. Little Lynch nodules are things on the back of the eye. Neurofibromas are lumps and bumps under the skin. And tibial bone is in the leg. You can have abnormalities with when you're born with having an abnormality of your leg bones. So some of these features we can see in some of the people with CMMRD. So there's a lot of overlap. So sometimes the way people have heard about this condition is they think that they have NF1, but it's really this but this has a higher chance of developing cancer. And then when you have Lynch syndrome in a family, you kind of look at the other way. You know, if I've got a partner that could be at risk for Lynch syndrome, is there a chance of having it? So the primary cancers that we see are hematological, which we haven't talked about at all today because we don't usually see an increased risk in heterozygous or one gene being abnormal for Lynch syndrome, but we see this in the CMMRD. We see brain tumors more often, and we see early onset colon cancer, so a lot earlier than we see with Lynch syndrome. So there are some published guidelines since 2017 that came together with two different publications, two different groups that have consensus guidelines on what we should do for children at risk for this. There are some discrepancies, and I will say the second one, I'm involved with an update that should be out next summer. So if you're worried about this or there's someone in your family at risk, there will be new guidelines coming out that shouldn't be too different. But some things to highlight, there's some differences as far as when you should start endoscopies, but it's early childhood, not the age 20 or older that we've talked about. We start MRIs of the brain at least by age 2. Some people say just at diagnosis and then every 6 months. Some people say in the first year to start with head ultrasounds. When your brain's not fully put together with the skull, you can do ultrasounds instead of MRIs in the first year of life. And then there's a discrepancy as far as do you do urinalysis for screening or abdominal ultrasounds. But that's really what we do about it to prevent the cancers, or if they do develop, to catch them early so the outcome is better. Now, have any of you ever known a child with Lynch syndrome who's gotten cancer under age 18? Okay, so there's a couple. It does happen, and it's not always CMMRD. You can have Lynch syndrome present in childhood, but it's rare. I only saw 2 hands up because it's not very common, and therefore we don't recommend screening for cancer in childhood, but that doesn't mean it can't happen. So it's important to just be aware that even though we don't do anything about it for children, that there are some cancer risks to be aware of, so that if there is bleeding or some issue or symptom, that you go to the doctor and you check it out and say, this child has a family history of Lynch syndrome. We actually published a case series of different cancers that we've seen at Children's Hospital with pediatric onset cancers, and with only 1 mutation and not 2. So another thing that has come to light is, how do we decide you've got children with Lynch syndrome that have cancer, and then you've got CMMRD, but sometimes genetic testing isn't perfect and can miss things. So how do you decide if someone just has Lynch syndrome with a pediatric cancer, or do they have CMMRD? So luckily I had the opportunity to be involved in this project that was published a couple of years ago, where we kind of outlined how you decide if someone has a CMMRD diagnosis or not. And I think the most obvious is what I was explaining, where if you've got 2 abnormalities, 1 from each parent, that is what causes the CMMRD. But there's a lot of different ways people present where it's just not clear. And so there is a consensus out there as far as what we can do to try to decide what to do and what screening to follow based on that. So that being said, should we test children if they're at risk for things? It depends. So there's a lot of guidelines out there about the ethical and professional recommendations as far as should you test children for conditions where management's not going to change till adulthood. Things say, it's only acceptable to do genetic testing in children if there's preventive actions before adulthood. So really, based on screening recommendations, it's ethically appropriate to test for CMMRD, but not Lynch. But it's the same test, so that's a little complicated. There's also deferring pre-symptomatic and predictive testing in children is recommended. It's recommended to wait till they're older. It should be deferred is another recommendation. But there's an exception that might be made for families for whom there's diagnostic uncertainty or there might be psychosocial burden. I don't know how many people in the room are uncomfortable with uncertainty, but that's a common thing that people feel, and our children feel that too. So there can be psychosocial benefit as well as psychosocial harm to testing children. And then There's also points made about facilitating predictive or predisposition testing of children for adult onset conditions can be justified in certain circumstances. So basically, children should have a right to an open future. And that, therefore, if you can delay testing, if it's appropriate, if they can wait, ideally we want to wait till children are older and can make their own decision about genetic testing. But there's a lot of circumstances and arguments for considering it. And really, that's where I advocate for genetic counseling, where we can really sit down and talk about in each child's circumstance whether it makes sense. So it also depends on the age of the child. There's different things throughout development that make each child's situation different. So if you test an infant for either Lynch or CMMRD, they have no awareness that they've even been tested at all. There's no way they can provide any assent or consent for the test being done. And they will have no recollection that it's been done. And the whole goal of why we're talking about everything today is we want to keep people healthy. So if you don't have the knowledge that you need to do things to keep yourself healthy, it's not very helpful. So you need to have future disclosure to them of letting them know that they're at risk. There's also, as children get older, they might have some understanding that they had some sort of test. Like, I remember spitting in a tube, or I remember getting my blood drawn, but they might have no idea why. And they'll need additional counseling as well. And there's, from a developmental standpoint, there's this, I mentioned uncertainty. I think that's one of the challenges as far as why people sometimes don't want to wait, because living with uncertainty through your whole childhood can be tough. And you can normalize things and say, you know, if you know your whole life what your risk is or is not, it's much more straightforward of how you can normalize that. However, then you've got this diagnosis that you're living with for a lot of years that you can't do anything about. Kind of take away the hope when you test too early. But you can also get a relief if you find out a child tests negative. As children are getting older, they may be able to concretely understand what they're being tested for and why, but child's brains aren't fully formed. So really comprehending and making an independent adult decision about it is not the same as testing a child whose brain is still developing. And then they're also, at least at some point, becoming reproductively capable. And so when you think about, 18 is really just a social thing that we put in the sand. Really, you're able to have children as soon as you hit puberty. And people that have hit puberty can have children. So when it comes to passing on a genetic risk, sometimes it's perfectly relevant to know whether you're at risk or not, if you might be having children of your own. For teenagers, the biggest job of teenagers is to form their identity. So when you test a child and they get labeled with something like Lynch syndrome, it's really important to think about how that may help or harm shaping their identity. There's 20,000 other genes in our environment and all the choices we make that make us who we are. And we don't want teens to make choices about who they are based on a genetic test result. And then there's also school. They've got a lot of other important things to be focusing on rather than genetics and medical things. So all of those things have to be factored into these discussions. Also, they're old enough to oftentimes want to be involved in the decision-making, having an opinion about the test, and having the results disclosed to them. And so it's an important consideration if a teenager is getting tested as far as how they want to get the results. Do they want the parent to get the results and tell them, or do they want the genetic counselor to tell them, or do they want it to be a group discussion? Those are all really important discussions. And then social support is really important too, in that we usually start screening for Lynch syndrome at about 20. So if you think about the trajectory of a lot of people's lives, 16, 17, you're technically a minor, but oftentimes you're still at home with social support. You're in your parents' environment where you have, like where you're going to eat and how you're going to get through the day and where you have to go for school and all that. When someone's 18 or 19, they're often trying for the very first time in their life to be an adult. And it actually may be not the best time compared to just a year prior when they're in a more structured environment. So I think there's some discussion to be had as far as if you're going to test sometime between 16 and 20, does it make sense to wait to 20, or maybe a few years earlier might be better, might not be? And you can also always just start colonoscopies at 20 if you're at 50% risk and not know your genetic status until you're ready. And then the last one is transition considerations, which I was just alluding to. But if you wait till 18, 19, it's a lot more straightforward from the standpoint of it's your own test, you own it. You can make your own decision about it without your parents, although I do see a lot of 18, 19-year-olds that their parents are still helping them make decisions. But legally, it's their own right, and it helps their privacy. So we talked a little bit about reproduction already. And we've seen the slide already talking about pre-implantation genetic testing. But I just wanted to go through a lot of people are diagnosed with Lynch syndrome. A lot of the time they're done with childbearing. And so we don't talk that much about all these options if someone's done with childbearing. So for people who are diagnosed younger, whether that's 20s, 30s, early 40s, or in childhood, we do have to think about what does it mean for the future as far as their options. So people that are concerned about their future reproduction have lots of choices. They can, like I mentioned, not test their children and just make sure that they get managed as though they are at risk, so that we're being on the safe side, and just get the management without genetic testing. They can stop the management if they do testing and test negative. If they want to test, there's lots of timing for that. They can wait till adulthood or when they know that they're at risk. They can test in childhood, like we talked about. They can be tested on cord blood right at birth. During pregnancy, they can be tested with procedures like, if anyone's heard of like a CVS or an amniocentesis, that can be used to test. Some people like to have that information for making decisions about the pregnancy. Some people like to just prepare as soon as possible. And then there's preconception testing, which is where the PGT comes in, where you use your own egg and sperm that you want to use in the lab, and you test and you choose an embryo that maybe doesn't have Lynch syndrome. You can also use it as an egg or sperm donor, or adopt, or have no children. But there's lots of reasons people decide any one of these choices if they're planning a pregnancy. And then before I conclude, I just want to highlight a few other things. When you say, what about the children? I think there's a few other points to be made. So it's important to think about not just what does it mean for them to have Lynch syndrome or CMMRD, or to think about their future and their cancer risk, but it's also important to think about what does it mean for them when they've got a parent with Lynch syndrome or someone else in their family with Lynch syndrome. And so survivor guilt's really common. So whether or not they have Lynch syndrome, just knowing that they've got a parent going through anything that a parent is going through can be tough. There's the trauma of when they're seeing their parent go through some sort of surgery or procedure or struggle. There's also the issue of siblings, and that if some siblings are at risk and some are not, and how does it factor for each sibling differently? There's also the aspect when we talk about the genetic testing that decision-making is not just the person being tested, but it's based on the guardian or guardians, and guardians don't always agree. So it's important to think about that it's not an individual decision if there's multiple opinions. That genetic risk may be the same as the parent if it's been inherited, but that doesn't mean the story is going to be the same. I think this is really important. That a lot of people that may be the first one in the family diagnosed with Lynch syndrome may have had some sort of really bad experience. But when you get diagnosed younger, preventatively, hopefully the story is going to be much better with preventive options and proactive care. And then there's also 20,000 other genes. So we're not just one gene. So I know you all know that. But I think it's really important to recognize that there's a lot of guilt a lot of the time of parents passing a risk on, but you pass on 20,000 other genes that are probably amazing. And so a few other things to just be aware of is that there's a lot more people getting diagnosed with Lynch syndrome. We've talked about this a little bit today, but we now are testing so many people with cancer of their tumor and their inherited risks. And there's also people getting whole exome testing of all 20,000 genes for other reasons that may incidentally find Lynch. And then you may also present with NF1 type features and end up having CMMRD. And you may also have symptoms at an early age, and it may actually be related to Lynch. So in summary, genetic counseling, I'd recommend at any age. If there's questions, concerns, you want to talk about it with a professional, I'd recommend genetic counseling for someone. Everyone always asks me, since I work at Children's Hospital, when should I send my child? Are you worried about it? Let's talk about it, whatever age they are. If no one's worried about it, you can wait. But genetic testing is an option, just it's only under certain circumstances. Lynch syndrome can present in childhood, but it also is very rare. And because it's so rare, that's why we don't have standard surveillance. But it's important for you all to be aware for the children in your family that if there are symptoms, to get them checked out and to advocate, which we've talked about. And then there is a recessive condition possible with the mismatch repair genes. It is also very rare, but there is increased surveillance to keep children with CMMRD healthy. It requires both parents to have Lynch syndrome, or every once in a while there can be a de novo event, which is where there's a new abnormality in the egg or the sperm, but it's super duper rare. And then I think my last bullet was that there's physical features also that present with CMMRD. So I want to thank you all for your attention and for being here today. And I look forward to the panel.